Our first panel this morning is going to be on the next wave of care delivery, the next wave of care delivery. I should introduce myself as we go into this. Of course, my name is Cliff Goodman. I'm a Senior Vice President at the Lewin Group, a healthcare policy consulting firm located near Washington, D.C. Our first panel is going to look very carefully at a particular aspect of the next wave of care delivery, and that is a perspective on the social determinants of health. And what you're going to see is three rather innovative people operating in different sorts of market areas who are trying to cope with social determinants of health. We're going to see what sort of approaches they're taking to try to account for these and try to integrate multiple kinds of service needs into something that can have an impact on patients. And our three speakers are going to be Rachel Gold, Karin VanZant, and Carter Wilson, all from three important aspects of the markets. And I'm going to start off on audience left with Rachel Gold. Rachel?
Yeah, good morning. Can you hear me?
Yes.
We're good? Great. I'm Rachel Gold. I have a joint appointment as an investigator at the Kaiser Permanente Northwest Center for Health Research, and I'm the lead research scientist at an organization called OCHIN. OCHIN is a really unique nonprofit that provides a full range of HIT services to federally qualified health centers and community health centers, and I'm going to be saying FQHC and CHC a lot as I'm speaking. As part of my role there, I've had two NIH-funded studies. One was a pilot study in which related to social determinants, one of the studies which we basically worked with community health centers to say, how can we get social determinants of health into your EHR? What are the EHR functions where those data need to live for documentation, for review, and for potentially taking action from a clinic setting on these social determinants? And we roll those tools out. I should say that OCHIN again serves about 600 community health centers on a single instance of Epic and about 100 on a single instance of NextGen. And so we rolled those tools out throughout our Epic members in 600 community health centers around the country. We're now tracking social determinants documentation in this very broad spectrum of community health centers. And then the second study that we're in the middle of right now is we're studying how do you help community health centers start collecting social determinants data, start documenting this. What are the implementation barriers that need to be overcome? So we're testing an implementation support package in community health centers.
Great, thanks very much. Karin, who you are, what you do in your organization, and how you approach this issue.
Absolutely. So I'm Karin VanZant. I'm Vice President and Executive Director of Life Services at CareSource. CareSource is a Medicaid managed care organization based in Dayton, Ohio. We have about 2 million lives that we cover in 5 different markets. We're in managed care in the Medicaid space, also in the marketplace, and we've just entered into the Medicare Advantage space. So mostly those government programs. My work and my background, I'm a social worker and community developer. I have worked for the last 20 years in the social services space and 3 years in healthcare. And my role is to help connect the dots between the over 80 means-tested social service safety net programs that are federally funded here in the United States with healthcare to build a more comprehensive and formalized response to the social determinants of health for our Medicaid recipients.
Great, thanks very much, Karin. We'll come back to what's working and not in a moment. Carter, what are you up to in Camden?
Yes, I'm Carter Wilson. I'm the Associate Director for Clinical Redesign Initiatives at the Camden Coalition of Healthcare Providers. We are a 501c3 nonprofit in the city of Camden, New Jersey. It is a small city, 9 square miles, 79,000 people, and a struggling city. 55,000 of those 79 are on Medicaid. We are persistently ranked first, second, or third poorest and most violent city in the country. So it's a challenging environment. I work directly in Camden, though we do have state and national arms. My work is with the primary care offices, hospital systems, and MCOs in trying to slowly build up our capacity to care for medically and socially complex patients in the long term.
You have quite the uphill struggle, sir.
Yes, we all do. Yeah.
But you said ranked 1, 2, 3 in what? Say it again.
Persistently ranked first, second, or third in poorest and most violent city in the country. It's also one of the hardest hit in the opioid epidemic.
Wow. Rachel, let's get back to social determinants of health and tell us, I know that you're involved in it at multiple levels, but tell us kind of the essence of what you're doing at KP to address these social determinants of health. And if you don't mind as well, remind us from your standpoint, what are the main social determinants of health,
Sure.
at least in your area?
Well, that's a lot of interesting, complicated questions.
Yes, you're up to it, I'm sure.
Of course. Well, I would say, I mean, that the most important social determinant of health is poverty. Poverty underlies basically all the other social determinants that we talk about. But why don't I talk? I think to get to your question. The Institute of Medicine, now the National Academies, a couple years ago came out with a list of recommended social determinants for screening, and I think I'm going to talk about those because there. We could talk about again like educational attainment, race, ethnicity, exposure to racism. Those aren't necessarily social determinants that are actionable necessarily from a clinical perspective. The ones that are more so, and those are ones that the IOM really focused on, are things like food insecurity, housing insecurity, transportation barriers, right? You can't, hey, I need you to come back to the clinic next week. Well, I can't. Right, I had to get a neighbor to bring me. Childcare. Just these basics that of sort of functional life that make it hard to access healthcare or act on care recommendations. So, I mean, we can also talk about there's community level social determinants that I think have some real importance, but aren't necessarily actionable from a clinical perspective. So what we've really been focusing on, very much as guided by the Institute of Medicine's recommendations, is are these actionable social determinants. The other ones I would add to that list would be social isolation is an important determinant that there are some ways that you can intervene with that. Partner violence is another one, although that's a whole other can of worms and complexities in terms of screening. So you asked me what I'm doing at Kaiser, but actually I'm going to tell you about what I'm doing at Ocean, because I have this joint appointment. Kaiser's my home institution, but all my research is with Ocean in the safety net.
Sure.
Although, since you asked, I will just tell you that Kaiser Permanente is doing some very innovative work around social determinant screening, and I'll talk a little bit about a partnership that I've sort of been fomenting between Ocean and Kaiser in a minute.
Good.
But my research is really on how do we support the safety net? How do we reduce health disparities that are experienced by patients who are served by our nation's safety net clinics? And I assume everyone knows what I mean when I talk about safety net clinics. I'm talking about public clinics that see people regardless of ability to pay insurance coverage. Yeah. So again, what we've been really, our question was, listen, we know the community health centers have been considering patient social determinants since their inception. It's really what they do. But there's never been a way for them to document their social determinants in a systematic way, have that information in the electronic health record, and use, again, the EHR to both track what's going on with their patient's social needs and potentially make referrals to community resources, adapt the care plan, depending on what the patient's social needs are. An example of adapting a care plan, my favorite, is if you got a patient who's homeless, you probably shouldn't prescribe a medication that needs to be refrigerated. You're going to need to change your care plan for that patient. Because
Sounds obvious.
Sounds obvious, but if the provider doesn't know the patient's homeless because it's not in the record and they didn't think to ask, then they're going to make a pretty serious, they're going to create a serious barrier to the patient acting on their care recommendations. So again, what we've been doing is studying how do we help get these data into the EHR. And we're very much building on work that was done by the National Association of Community Health Centers, or NAC, their PREPARE project. Maybe some folks might be familiar with the PREPARE screening tool. It's one of the three social determinants sort of screening tools that's sort of risen to the top. The other two are the set recommended by the IOM and the set recommended by CMS and their Accountable Healthcare Communities project, which is really exciting. We can talk about that later. So we're really, but starting to collecting social determinants data and documenting it in the EHR and doing systematic screening, there are significant implementation barriers to doing that. It's not, you can't just say, okay, we're going to start collecting these data, putting them in the EHR. And so what my teams are working on is, okay, well, how do we do this in a way that works? Mm-hmm. How do we help community health centers develop the workflows for doing the screening? And then again, there are reasons for and against screening patients for social needs that you maybe can't address. Again, in Portland, we've got a terrible housing crisis. So, if you screen someone for housing insecurity, is there something the clinic can really do? Like, maybe they can put them on a 3-year waiting list. That's, so there's some real tension there around. So there's a lot of decisions that need to be made for clinics, again, around workflows, which social determinants needs do you want to screen for, which patients do you want to screen, and they're trying to make these decisions without without adequate evidence to support which is the most important. You need, sort of obvious you want to screen for access to food, healthy food for patients with diabetes, but there's plenty of other, social needs and morbidity combinations that we.
So Rachel,
yeah.
but I'm taking home 3 things so far. One is that Well, you're recognizing that social determinants of health are real. Actionability, get it into the electronic health record, and systematic screening.
Yeah, and again, how do you, and to do those things, how do you make that feasible in community health centers, which is, again, where my interest lies, although I would argue that a lot of those barriers apply to any healthcare delivery system trying to document patients' social needs and how they're going to impact
But the
their health.
actionability, and you make a good point. If you're going to do systematic screening, you need to be looking for things that are not just, it's not just a matter of being aware of a social determinant of health, it's identifying a subset that are actionable.
Well, I think this is a great question. I was talking about it with one of my colleagues last night at dinner. I think it's both. I mean, even if you can't make a referral for something, again, like housing insecurity, you still want your care team, you want them to know.
That's the awareness part, because the example you gave was, if they don't have a refrigerator, it might affect what kind of care you give them. Got it. Okay.
Right, so, but I think there's a real tension there, right?
Yeah.
One of the things that we definitely found in our pilot study was that clinic teams, the staff were saying, man, I feel terrible asking patients about something if I can't offer them help with it. And so you don't want to make it a burden for the clinic staff. Folks who work in CHCs are already doing, they're doing the Lord's work already, you know what I mean? Like they don't need, you don't want to make their jobs even more stressful because, I ask these patients, they say, yeah, I'm hungry and there's nothing I can do about it. You don't want to put the staff in that position or the patients. So I think that there's that my work is really trying to get at how do we do this in a way that works for the patient, that works for the clinics, and that's efficient.
Those are the trade-offs you've got to consider. Karin, and then back to Carter.
Great.
Karin?
Yeah, so, and I think I'm going to say the same
We're
thing.
going to jump in.
Yes, I think.
Go ahead and say it.
So the thing is, there are resources available. There is always an answer. There may be a supply and demand issue depending on the geography that you're in. But there is an answer. There are pathways. It's about how do we knit the social fabric and safety net within the geography across the sectors. And so there are lots of housing providers that are trying to do this work, that are trying to find people and get them into the types of housing that would be appropriate, but they aren't necessarily getting referrals from the healthcare system or vice versa. And so I think that part of this is, yes, identification has to happen, and it has to happen in a dual way. The ways in which the social safety net needs to understand how healthcare works so that they can do appropriate referrals in as well. So it's a bidirectional, it's mutually beneficial.
So there is a referral, you've got to be good at triage and navigation, I guess it sounds like, right?
Absolutely.
And have the resources to do that referral and triage.
Understood. Carter?
But you need to move that kind of social service engagement upstream. So so if you're thinking about housing is the perfect example. And really, in many ways, kind of its own social services. Because if you try and set up these kind of flywheels for screening and navigation, they're going to be the patients that gum it up because there's just not enough housing. But there are other parts of housing that there might be plenty of resources in, preventing patients or residents from losing housing, preventing homelessness. But all those resources are community specific. And so if you can engage your social service providers, understand exactly what resources are available, and then tailor your screening questions to those available resources, then that's a better way to navigate. But I also want to push back on the actionability. In a lot of my primary care providers that I work with, they're really against asking these questions without the workflow in place because they don't want to open up this can of worms.
Right.
And I get that feeling. I think we all get that feeling, and I want to train them to be confident in asking these questions. It's only a can of worms for the provider. It's not for the patient.
Yes,
the patient's living this life.
Yes.
Yeah.
They're not
They already
re-traumatized.
know all of the information. Yeah.
They're not traumatized by their own life or talking about their own life. So it's a provider anxiety about what they're going to do to their patients, and it's incorrect.
You mean, does the anxiety arise because this is a difficult subject to discuss, or because I don't want to raise it if I can't help you do something about it?
I think it goes
Both.
to the knowledge, skills, and ability, right?
Yeah.
And so the ways in which we train.
The KSAs?
Absolutely. I think this is the way in which we train any professional. So whether you're an attorney or you're a doctor or you're a nurse or you're a social worker, you're trained in a certain way to think in a certain way and to follow your swim lane, right? But what I think we're seeing now and experiencing now, we need to start training across the disciplines. And it's okay to not always have the answers. You know, and no one is going to have all of the answers, especially when we're trying to address things like poverty and when we're trying to address global social issues that are manifesting themselves in our community, we're not all going to have the answers. But if we don't ask the right questions, if we don't start the conversation, if we're not collecting the right data points, we're constantly going to have incomplete care plans. We're constantly going to give people information that is not going to be helpful to them or relevant to their situation, mostly because we're not asking the right questions at the onset.
Remind people what you're doing at CareSource along these lines.
Yeah, so you know, I always feel like, especially when I'm presenting to a group that is historically in the healthcare sector, I'm not. But this work really, I think, the 20 years of working in community development and social work programs, things like TANF, cash assistance programs, food assistance programs, housing programs, workforce development programs, I think has created this cross-sector work that I'm able to lead now. And so a couple of the programs or pilots that we've been running in Ohio and in the last year or so have started to replicate in our other markets of Indiana and Georgia, have a workforce development component, voluntary, allowing members to come in, expanding our clinical care model. We've always done, we're also a nonprofit 501c3 healthcare plan. We've always gone above and beyond for our members, but we've never had the formalized tools. So it was always very dependent on the staff person that the member worked with and how well they understood the geography or what community you lived in. The more rural you get, the less there might be resources there. And so how do we formalize those responses, make sure all of our member-facing staff have the tools, have the knowledge, are asking the right questions? How are we integrating our health risk assessments that our states ask us, which are very clinically focused? How do we start adding questions to those so that we start getting to the socioeconomic status of our members? With our workforce development program, it's called Job Connect. We've actually worked with almost 10,000 of our members in a voluntary way over the last 3 years. What we've seen is 6,000 of them interact with a life coach. These are folks that have a social worker, human services background, or they themselves have come off of government subsidies and have made that transition into a helping profession role. And they have a lot of the institutional knowledge of the neighborhoods where our members may live and how to access the local resources, the ones that usually aren't on the map, that informal network that typically is a part of our low-income communities. Another program that we've been working with since 2016 is with our Ohio Department of Mental Health. It's called the Community Transitions Program. And so we're actually working in the Ohio prison system to help those that have substance use disorder, behavioral health, or mental health diagnosis and have been receiving treatment inside the prisons to go and help them become eligible for Medicaid, pick their plan, figure out what their care plan is, wrap around temporary supportive housing and then permanent supportive housing for them, and helping them to transition successfully.
So you go into the prisons before they leave, try to get them, 6 months before, okay.
And what we've seen of those two different populations, and there are some crossover, 40% of the folks that are coming through our Job Connect program have SUD or criminal justice in their background, 40% of that 10,000 group. And are moving into education training and into employment, as well as those that are coming out of the criminal justice system. But what we've seen is we're tracking now the health data and the economic data from this subset of folks. We follow folks for 2 years after they start employment. We're seeing a reduction in recidivism rates of those that are voluntarily enrolling. 2% have gone back since 2016. The average in Ohio is in the 30% for recidivism rates.
Wow.
Huge ROI, but not a huge ROI for the healthcare system. It's a huge ROI for the criminal justice system, right? But it's a huge ROI for our communities where these folks are going back to. And so when we think about where the ROI is coming from, it can't just be the healthcare sector only. We have to look comprehensively across this. With our folks that are moving into employment, 80% of them, 86% of them are staying on the job at 90 days, 82% of them are staying on the job at 6 months. And we're seeing folks actually move off of some of these government-assisted programs or subsidy safety nets. We're addressing cliff effects with them. And what we know is for every adult that we can transition off of Medicaid, especially in our expansion states, across all of the safety net programs, we're actually saving state government, county government, about $25,000 per person per year as we transition off. So again, it's not necessarily an ROI just in the healthcare sector, although we are seeing a decline in ED utilization, we're seeing a decline in inpatient costs, we're seeing an uptick in wellness, but it is across the service sectors, and we have to start thinking about how we have comprehensive ROI across these programs, especially if we're going to address things like poverty.
So Rachel, do you have an insight on that issue?
Well, I would just want to underscore, I mean, what you're talking about to me really, it speaks to one of the questions that I think is at the cutting edge of this field, which is how do we close the loop? So the example then from where I'm coming from is, how do you, if you're going to have a community health center, make a referral to a food bank or some other social service agency, how do you, what is honestly the technology, the data exchange involved so that both you can, so that the agency can be told by the clinic, hey, this patient is coming, and there's a way for the clinic to let for the agency to let the clinic know back, great, this patient showed up or didn't, right? I mean, that was, so then the agency, because otherwise the clinic's like, well, I referred you to a food bank. Well, what happened? You're not, so that how do you close the loop between medical record keeping in the medical system versus in the social service agencies or justice system, et cetera, that the need to connect those, to have data exchange between those sort of agencies so that we can really serve patients better is critical, and yet really no one's really figured out how to do this yet on a large scale. Right. I would be happy personally just to figure out how to have the clinics and the social service agencies be able to let them know. There are some folks doing some innovative work in this space. The one I'd call out specifically is called NowPow out of Chicago, but they're for profit. They're trying to there's a cost involved, right? And for a community health center, that's a bit prohibitive.
So in all these instances, it sounds like you need really explicit, detailed, on-the-ground awareness of what services are available in your geography, as it were.
Very much so.
And the ability to make the connections.
I see really two big barriers in terms of, and this is just coming from the perspective that I represent, which is the primary care safety net. One is how do you make sure that the clinic staff that would be making referrals to social service agencies to address social determinants, that they have an up-to-date list? You'd think that would be easy, but it is incredibly difficult. And now there's a lot of folks working in the space, 211, Aunt Bertha, Purple Binder, et cetera, that create these kind of lists, but again, they're not free. And so that becomes a barrier. They're also sort of geographically kind of patchwork, some serve some communities and not others. So we need to find a way to help community health centers have these up-to-date lists. So we're talking about innovation. I'll speak now about that partnership between Kaiser Permanente and Ocean that I've been sort of fomenting behind the scenes. Kaiser is going to create what they're calling a social services resource locator for all of their regions, so that there is an and they're going to hire one of these agencies that create these lists, and Kaiser's going to pay for that, so that for within their regions and their patients, there is in the EHR an up-to-date. Okay, what are the food banks that are currently active in this person's zip code, et cetera, and they're planning to share that resource with a safety net. So Ocean has sort of jumped on as a partner from the beginning because there's a lot of overlap there, and so I'm hoping that will become a model where we can.
As an example, good. Thank you very much for that. Carter, just at the Camden Coalition, what are you experiencing along those lines?
Great, and I'll go do a more high-level overview in just a second, but we are working on this very thing. So we're in the early stages. We partner with Aunt Bertha, who's one of these platforms, used under the Accountable Health Communities model, which we were a recipient of. We built out, previous to receiving this actually, Aunt Bertha as a social service resource. Aunt Bertha.
Not everyone knows what Aunt Bertha is.
Aunt Bertha. And then we branded it locally as My Resource Pal. But it's an online resource directory that we have tailored to our community, so we have exactly what resources are available for which patients, how do you access them, all that information is downloadable. But then we're building in our social service screenings onto the platform, so it can automatically map to these available resources.
But is it in your EHR?
So it's going to be. So we run a health information exchange, and so phase 2 will be linking it to our health information exchange, which is now then pushing down to all of our primary care practices.
So we're doing it similar. It's interesting. We're partnering in my study where we're sort of literally studying how do you help CHCs do this. We're partnering with our local Accountable Healthcare Communities project, which is led by Bruce Goldberg out of the Oregon Rural Practice-Based Research Network. And because we realized that we had some clinics that would be eligible for our study that were also part of that AHC project, the Accountable Healthcare Communities Project, and said, oh, but you're gonna, and the way that they were setting up to do this is to say, great, we're just gonna send, it'll be a web interface, and we're gonna send the patient, we'll report the patient's social needs through the web, and it'll send back, it'll send it to CMS, and everyone will be happy. But the clinics won't be happy because it's not going into the EHR, and then you're collecting data from a patient that you then have no way of tracking later. That's not a reasonable solution. So we're kind of doing a little mini pilot with them in our partnership to say, well, can we create an interface so that you can just enter it to the EHR and it gets sent to CMS?
So Carter,
but that's what I'm talking about, is those kind of data
how are you
exchange.
managing that, Carter? How are you managing that? And then I do want a bigger picture for Camden. Go ahead.
So we're in the infrastructure building phase, and that's true kind of across our work.
Infrastructure building phase, okay?
It's setting up social determinant screenings and kind of pushing that out to all of our partners. It's setting up the data transfer. It's making those linkages, which is messy and patchwork. I don't want to say that we figured this out. Right? It's setting up the trainings to make sure that providers are prepared with harm reduction and motivational interviewing and trauma-informed care and can have these conversations. That's all infrastructure building. And then it's kind of the little mini pilots. We also have it's not a prison, but a jail transitions pilot. We have a housing first pilot, right? We have all these little pilots that we view as kind of infrastructure building for this field. And then kind of more broadly, on the national stage, we've launched the National Center for Complex Health and Social Needs, which is meant to be this kind of professional home for this work of this emerging field of complex health and social needs. How do we take these little learnings and these pilots? How do we make sure that we're sharing that with the larger community?
I'll put in a plug for your conference. I just want to say they run a terrific conference, and I recommend it.
Thank you. I know San Diego is great in May, but Chicago in December is where you want to be. December 5th through 7th, the 3rd annual national conference. Thank you.
So Carter, what then, you're in one of the toughest geographies in the country, as you pointed out statistically. So what are you doing? You say infrastructure building. That sounds like kind of some basic stuff.
Yeah.
Are you still trying to accomplish the basics, or is there a new wave? Are you trying some different things because innovation might be needed in such a tough market?
Yeah, so I do want to say, yes, it's a very challenging environment. The city of Camden is filled with beautiful residents and providers that have been serving for a long time. So just make that plug. I think the new wave is infrastructure building. So I even think about just our core program. It's called CMI, and it works with medically and socially complex individuals. We meet them in the hospital. We follow them in the community. We work with them for 3 to 6 months. We wanted to evaluate that program. But in order to evaluate it, we first needed to make sure that we weren't running as many interventions as we were patients we were serving, right? Because these are unique individuals, right?
Wow.
That have unique combinations of complex factors. And even our healthcare providers, the people working with these patients, didn't have like a uniform way of working with the patients regardless of their needs. So before we could go to evaluation, we had to kind of categorize, classify all of the things we do. We came up with 16 domains. 13 of them would be considered social determinant areas. We then
16 domains.
16 domains of areas we'd work with, like advocacy would be one, but ID support would be another, education and employment, right? All the social determinant areas, housing would be a huge one.
Food.
Yep, and then there's a wild card. There's the things you don't predict that come up just in an individual's life. So we had to kind of figure out exactly what we do, protocolize all that work, and that was important from a healthcare delivery standpoint too, because our most valuable resource was the people that knew those services, and they were walking out our door every day. That's a huge risk for us. But we had to protocolize what a complex intervention looked like, and how do you work with a patient? How do you determine that a patient's eligible for graduation in a short-term intervention?
Wow.
We had to do all of that really hard work before we could even think about evaluating the program. So right now, we did all that, and this was a program that we've been running for 10 years. And now we're in the middle of a randomized controlled trial that should be done in the next year or so, conducted by MIT.
So clarify then, if you got, I'm so astounded, you've got to work in 16 domains.
Yes.
Everything from, you got housing, food, substance, all this stuff, domestic abuse, all these things. When you say you're doing something innovative in infrastructure building, is that because there has not heretofore been an infrastructure that embraces 16 domains, and this is a new kind of organization? What do you mean?
Sure. From the healthcare perspective, I've been at the coalition 5 years, and for the first 3.5, when I would go talk about social determinants, I was talking about the ACE study, I was talking about American healthcare paradox, right? I was teaching the audience about social determinants. That's now a ridiculous presentation. Like, most people understand social determinants, and I wouldn't need to do that, and it becomes the what? We just got here. Like, we just got to the point where everybody agrees that this is something we're talking about, and My concern is, even the phrase new wave, I understand what you mean by it, but my concern is that people are looking to the next hot thing. There's not a hot thing, we're there. We now need to build out the infrastructure that we can start testing the interventions and develop the learning. So it's not sexy, but infrastructure is, in my mind, the new wave.
And to that point, I would say not just build a new infrastructure, but there's an existing structure that needs to be decimated. I mean, it's not like addressing food insecurity is a new thing. Like, that's been around for a very long time, right?
Yep.
But there is an entire food structure that could rival the healthcare structure. There's an entire housing structure. And so when we really talk about silos, truly think about all of the aspects of your own life that you are having to juggle and manage as a professional, as a parent, as a corporate citizen, all of those things. And think about the various systems that you have to go in and out of and how long it took you to understand those various systems. And then back out all of the knowledge that you were given for the first 30 years of your life about managing those systems and replace that with a clean sheet of paper. So that's somewhat what we're doing for our 18 to 25-year-olds right now, is starting with a clean sheet of paper, as they really do not understand how to look at systems, how to think about the complexities across these systems. And each one of the systems is disconnected from the other, yet Mrs. Smith needs to access them all, right? And so there are infrastructures that have been built. We just have to figure out how we start to unravel the existing system and tie them together and weave them together more like a fabric in the community that recognizes each individual part of Mrs. Smith's life.
So your role then is not to necessarily destroy the 16 or more, whatever they are, silos, but to link them. So the functions you want to largely retain, but the connectivity is something you've got to make happen. Is that an appropriate way?
And we have members right now that they depend on anywhere from 7 to 10 programs, whether they're at the local community level, state or federal level. That's what they depend on week to week, month to month, year to year. Many of those programs have their own case management functions.
Yes.
They all have their own rules and eligibility and requirements. They all have different ways in which you have to report to maintain your eligibility. And so we have lots of people helping to maintain, especially in the social safety net, a lot of these programs they know that they're not doing anything in housing, but housing is critical. They know that they may not be doing anything in food, but food is critical, because the requirements and the parameters around the program or the sector that they work in say they can only do this. Just like in the healthcare sector, we don't necessarily think that Medicaid should be paying for XYZ workforce development or housing program, because there's billions of dollars already targeted to that, but we're not connecting the dots into the healthcare system. And so when we talk about this comprehensive approach, we talk about this kind of new wave, it is the recognition that people are whole people, and that they're going to cross very complex systems, no matter what their socioeconomic status is. We all are going to cross these complex systems in our community, and they're not connected. I mean, think about how easier your life would be if some of these things were all connected for you and you didn't have to go to 18 different places to get something accomplished.
So then, Carter, how are you operationalizing this? Is it a break down the silo but connect the function issue? How are you making this happen?
Yeah, so up until a couple years ago, the talks was case management, how do we get healthcare quarterbacking this work, right?
Yes.
And I think we fell into that a little bit too, which is, we just need, based in the healthcare field, we need people that are just making those individual connections, but without any meaningful collaboration and alignment in operations with these social service providers. And so as I'm thinking about ramping up our work with the Accountable Health Communities model, which takes us out of Camden into 3 counties on a much larger scale, 75,000 unique screens, 3,000 navigations each year, I'm appreciative of CMS for the model, but I'm going in with questions that haven't been developed in collaboration with these social service agencies. And so I'm already kind of having to rebuild some of that trust with these agencies as I'm starting to collaborate with them.
Are they threatened by you? What's the deal?
No, I think they're eager. I think they're eager to partner with us.
Yeah.
But there is, healthcare just got here, and it's like they've just been discovered, by the healthcare field.
We've been doing the
known
work
this
for 100 years.
They've known this, right? So I think there's a little bit of resentment that's not stopping them from wanting to partner. Right? I see eager partners. But when I'm thinking about that kind of health communities, if I could do it over again, it would be work with them to develop the questions, but then also partner with the operationally really efficient organizations that are prepared to align operations with us in the community. So I'd find a food security group, 2 or 3 that have the ability to kind of work with me to tinker our connections, and I'd start with the ones that are pretty strong already. So I wouldn't pick 5 that are highest correlate to hospital use. I'd choose the ones that we have the capacity in the community to activate right now.
So one of the daunting things that arises, though, is it would seem that the various services that you're describing all have their own eligibility criteria, funding, and if I walk in as a patient or a consumer, I may be more or less eligible for those things, and I might have sort of my own set of challenges regarding how I can access those. So how do you do you have to tailor an approach for each patient or each person depending upon their eligibility for food as opposed to housing, as opposed to prevention?
Yeah, I mean, the question is, where do you start, right? There's going to be gaps. There are gaps exist, but where do you start, right? And so you find these really competent social service organizations, and they're out there, and you work with them on figuring out what opportunities there are for screening, and then you slowly build from there. This is a new relationship. And you need to get in there, you need to start small, you need to figure out the learning, and once you figure out that, then you can replicate in other organizations. But one of the challenges of the accountable health communities is you can't do that. You have to start in these 5 areas regardless of what strengths of the institutions are in this space, and we're going to so that's
But I also think that while that work is happening at the ground level, and that's where the action and the change is going to happen, is at the individual and the patient member level. There needs to be just as much emphasis at the national level to really highlight and to start the advocacy work that needs to happen around the rules and the regulations that govern all of these different programs and the different buckets of money that keep everything so siloed, and think about the ways in which we could reorganize the $1.5 trillion we're spending on safety net programs to actually have outcomes attached to them, to actually move in the direction that healthcare's been moving, which is to how do we pay for the outcomes? How do we pay for the performance? How do we really truly work with individuals around the types of deep-seated behavior change that needs to happen to truly address what's been growing in our community.
So Karin, do you have the sort of strength and willfulness to try to overcome all that fragmentation? I mean, to me it sounds terribly daunting to try to navigate across all these independently funded services, some at the state level, some at the federal level, some local. Can you make this happen?
Well, I think there's definitely some advocacy groups out there that are really taking it on.
Yeah.
There are waiver authorities in a lot of these programs. There's waiver authorities in Medicaid and in TANF, and I think states, obviously states are not getting richer. They're also looking for ways in which to balance their budgets and to think about ways that they can use their resources to get to better outcomes for their states. And so when we think about, yes, it's very daunting. I've had lots of elected officials tell me, like, you're going to need somebody better than God, like, to figure this thing out. Like, and part of the problem is that the social safety net that includes a big chunk of healthcare wasn't developed overnight. It was developed over the last 70 years, and a lot of the programs that exist there were put in place for very well-intended reasons, but we've never really, as a country, taken a step back and assessed all of these programs, looked at the spend that we're putting into all of them, and really tried to understand where we could be investing in better types of evidence-based types of models.
Got it. By the way, in about 4 minutes, we're going to go to your questions and answers. So if you want to gin up a question pretty soon, that's great. On that point, Rachel.
I agree with everything that's been said, but I'll be a bit of an optimist here and say I hope that now that it's as you said, now that I don't have to go and explain to people what social determinants are and show them the diagram showing that only 20% of health is driven by clinical care, and that there's really a great understanding that social determinants drive health. I'm hopeful that now that shift in consciousness has happened, and knowing how much money we as a nation spend on healthcare, that we spend lots more than most other countries with worse outcomes than other developed countries, and it's clearly not needs to be improved. But I think having the healthcare system start to pay attention to this is a positive. I mean, I think that this is a way that that all of this. And I think, and we're healthcare systems have sway in the community, and I think that we might, because now that healthcare providers are starting to say, gosh, these social determinants are driving our patients' health and our costs, that maybe that's where we start to get that what larger than God, right? I think some of the healthcare systems are, right. So maybe that's where we start to get. We start to have that ability to bring all these different systems together. We've got a driver, and I totally hear what you were saying, right? That if I'm a social service agency, right? I've been doing this for 60 years. I'm like, oh, now you're paying attention, Kaiser Permanente. That's great. But I think that if it does need to be driven by the big guy, then I'm glad that that's happening now, and I'm hopeful that we can take the healthcare system, the various healthcare systems, from the big players down to the individual community clinics, and start advocating to making these kind of connections. I mean, I certainly see there being logistical barriers to doing this. I mean, this exchange, the data exchange, and I'm a scientist, right? I want the data. I want to see the relationship between how much money got spent and what the services were and what the health outcomes were, so that we can make the case that you're talking about exactly for, we're spending all this money on this, and this isn't actually getting us to better outcomes, to cost savings, but we don't have those data connected in most cases, so we don't have the ability to do that yet.
Let's pursue this for a second.
All
then.
right.
What are you seeing, because Rachel just brought up the outcomes. Karin, Carter, what are you seeing, or are you seeing anything thus far about an explicit kind of cause-effect relationship in what you're doing and improved health outcomes? Can you point to anything in particular?
I can point to one thing.
We'll take it.
Housing first.
Okay.
Housing first. Do people know the housing first model? Right. So previously in housing models, right, there's a kind of a step up for you to get permanent housing, and it's just really difficult to climb that ladder.
Yeah,
and,
right.
And housing first is saying we're going to put you in a house, and then we're going to wrap you around social services. But we're going to start with housing because you need that housing, you need that stability in order to improve your health outcomes. And we didn't develop the housing first model. We brought it to South Jersey a few years ago. It's a small pilot, only 65. It has not been robustly evaluated because we need 2 years pre and 2 years post. We're not there yet. But from what we're seeing pre-post, it's something like a 60% reduction in inpatient and ED utilization. 60.
Whoa.
Now, it's a weird measure because it combines inpatient and ED. I don't know why they chose that. Yeah. But 60%, we're also seeing an increase in outpatient and desired medical spending, day programs, and an increase in patients reporting that they no longer need help in addiction support 1 year after housing. So housing is, there's a clear, I think the evidence is emerging
as an intervention,
as a pretty great intervention. Everywhere else, it's a lot harder to tease out, and part it's because of the data transfer, right? You can't just measure on the healthcare side. You need all this information in social service, and jails, and police support, and all these other areas. So it's a lot harder to point to. And I can't even do it for the program we've been doing for 10 years, though I hope to be able to in a year.
Oh no, Karin, some of the stuff on recidivism you cited before.
So we are tracking, and of course our work got started in 2015 and 2016. So we're not there yet for having enough time when we look pre and post, and having enough people that have gone through the process. But in 2017, we did take a snapshot of those that were in the Job Connect program, and what we did find, 6 months of their participation as a CareSource member in Medicaid without coming through Job Connect, and then 6 months, or a minimum of 6 months after the intervention of working with a life coach. We did see a reduction in ED utilization. We saw a reduction in the cost of inpatient. We saw an uptick in wellness activities, so getting their annual checkups, mammograms, dentists, things like that. We also saw an uptick in our RX. And so we wanted to dive into that a little bit more.
Your RX, your prescriptions?
The prescription spend, yeah. We wanted to dive into that a little bit more, and that's where we found that 40% of the people that were in this population had SUD, mental health, and criminal justice background. Many of them were now starting to enter into the recovery phase because we are a little bit different in our approach. You don't have to be all ready to go into employment to come into the workforce program. We'll take you as you are, you know, and so that for us is giving us hope. In the criminal justice work that we're doing, though, and it goes to housing. So I have to say, of all of the folks that have come through the program and chosen the permanent supportive housing route, there are almost 300 of them since 2016 that have come through. That's where we see our 2% recidivism rate. It is about the transition, that wraparound care, the supports that are in the housing, but having a place to lay your head every night is critically important to every other outcome that a human being would have.
Good to know. Thank you. Rachel, on that.
To exactly to that point, I hope that a take home from this talk for everyone is understanding that there are lots of, like, there's 1,000 points of light, right? I keep saying there's lots of pilot efforts in this area going on now, and just like you guys both said, many of them are recent, have started in the last few years because this cultural understanding has shifted, and that's great. But what's not great is that a lot of them are not being reported yet. So it just drives me crazy. Where there has been, and when I say reported, I mean in the scientific literature, because that's my framing. But I would put in a plug for the Siren Network website. Siren is the Social Intervention Research and Evaluation Network. It's based out of UCSF. And they've created a website that's got all the social determinant screeners that have been developed that are out there. You can go to their website and look at them, and they've also are creating a collection of all of the scientific evidence on social determinant screening and intervention. It's just a great resource. They did not pay me to say this. I use it every day, and I would recommend if you want to get into the literature on what has been scientifically shown in this area, the Siren is a great place to start.
Good resource. Questions at this point? Does anybody have any questions or comments to make here on any of the issues that you've heard? Row one, gentleman here. Wait for the mic if you wouldn't mind, and name and affiliation, please.
Hi, my name's Chris Crowley. I'm from the West Health Institute. I wanted to ask about the money because there's obviously this growing awareness of the role of social determinants, and on the heels of that, there's this growing interconnectivity. But the money is an important question. I want to know if there is enough accountability and risk sharing on the part of health systems, number one, and number two, is there enough of an understanding of kind of what I think we're hinting at, all three of the panelists, in terms of the cause and effect relationship, where if I, as an accountable health system, am responsible for excessive ED visits, excessive hospitalizations, do I actually understand where I might be compelled to invest in some of these resources? Because many of these community resources just don't have the budgets. These things like aging and independent services, food banks, housing, they don't have the resources. But I think, as you described, there's these $1 trillion kind of monolithic health systems that.
Well, a couple of thoughts and then
Just briefly, yes.
Oh yeah. One is that there are some models around paying for these services that are starting to come out. The ACOs and CCOs, I think, are an exciting model around, hey, we're going to pay you. You will get reimbursed for your care management time, right? So that's exciting. And then your question, I think, speaks to one of the reasons why it's important to screen for some of these social determinants, even if you don't necessarily have a place to refer, because then you can start collecting data and saying, man, we've had 5,000 patients come through this year that needed food resources that we didn't have anywhere to send them. So then you've got a policy lever.
Karin, do you have a response to that?
Yeah. So interestingly enough, we, because I work at a nonprofit MCO, we decided to go ahead and self-fund the concept of this back in 2015. But what we have found, and even some of the most recent guidance that's come out of CMS, even with some of the 1115 waiver information, is Medicaid is not to be spent on these types of things. There are other states need to partner with the other groups that have housing and workforce and education dollars to be able to blend those resources together. And so we've taken it upon ourselves to be more of an intermediary or a convener of those dollars And interestingly now, we're doing it, it's not scalable. We definitely need policy change for this to go across at least our footprint and be a demonstration. But we now receive Department of Labor dollars, we receive HUD dollars. We're doing it on our own because we believe that this is the right way to go. But it is administratively burdensome to do that at the organizational level, to start blending these things together. And we're not doing it in a way that would push out the existing housing provider. We're partnering with HUD, coming alongside of our local HUD provider and collaboratively going after the demonstration dollars in HUD to bring them to our community so that we can prove these things out. And I think that's an important thing, and it goes to your comment in Camden. We can't come in and say we're the big healthcare group in the community, and now we're going to take over housing or food or whatever. We need to come alongside those that have the institutional knowledge of how these programs work and the people that they've been serving, and help build those kind of collaborations in our community.
Sounds like assembling a jigsaw puzzle. I mean, you're not kind of taking everything over. You're trying to make these connections.
Yes.
Yeah, and to your jigsaw puzzle, we're like doing a jigsaw puzzle without the front of the box.
Yes.
Without
That's right. Or
seriously,
funding. Or funding.
We're pulling the various pieces that we can identify together, but we don't truly have a clear picture of what that can look like. We've never really done this before.
Point very well taken.
And so, you you think about that.
Right.
We haven't figured out the picture on the front of the box
We
yet.
don't, and we haven't collected, and it's a chicken and egg. We haven't collected enough individual level social determinants data to be able to do the analyses to show what is actually associated with, right? So it's the same deal. We're all kind of
At least heading in the right direction.
walking into this backwards.
Next question, row 3, name and affiliation.
So Dennis Scanlon from Penn State. So I want to follow up on this kind of policy point, the point about what Medicaid will or won't allow you to do, and because it seems to me that if we don't sort of align these policy and budget streams, then we're doing patchwork at some point. And so just an example that I've been working on in Pennsylvania with a health system. Health system has a number of patients who have excess stays beyond being medically cleared for discharge. And they just can't, they need some supervision, they don't need skilled nursing, so they can't get them out of the hospital. The hospital's at capacity, so they can't take in new patients. A lot of these patients are paid for by managed care, Medicaid managed care, which has absolutely zero concern about long hospital stays, given that they pay based on kind of DRG-based payments. So the patient could be in 5 days, it could be in 500 days, and I guess as we've looked at this situation, there's a huge amount of problem from various policy streams where money's being spent that's being wasted, right? So skilled nursing facilities are getting these patients that don't need to be in SNFs.
Right.
And patients who do can't get in.
Right.
So you're paying too much for patients that don't need it, and the patients that need it can't get in. The Medicaid managed care plans who have these contracts have zero responsibility for patients that are spending time in the hospital when they don't need to, because of the way our state at least kind of writes those contracts. We have a contract for long-term social support services where they're getting money for patients they can't provide support to because they're in the hospital. So if you sort of put it all together, the state and I suppose the federal government, to the extent that they contribute with, really could, if you could get the policy pieces in line, which is politics, and that's not easy, we all know, I think you could maybe potentially make some headway here. But it's just been very difficult to do. Somebody made the comment earlier that your legislators can't get their hands around this. I think that's the same case. But I'm wondering if any of you have made any effective headway, because I think it's just patchwork unless we can really start to, with state budgets and how much we hear about under pressure, this would seem to be an issue that Democrats and Republicans, in terms of addressing state budget issues, should be able to align around.
Carter, can you pull that off in New Jersey of all places?
Yeah, so you're right that we can't just focus on the healthcare delivery. We are focused on kind of 3 levels. The delivery and figuring out what the right models are. We have a state level advocacy campaign. It's called the Good Care Collaborative, where we pulled together other communities in New Jersey to help figure out what is good care, what are the policy levers we need. Is it we need some of these to be claimable expenses? Do we need to use quality improvement arms? Value-based, we're a Medicaid ACO, community-based Medicaid ACO, and then you need the national level, because, this feels like an impossible task if you're thinking about the community. And I spend my day in Camden thinking about Camden, and it's only when I have opportunities like this, when I come up and I realize I'm not an island. There's a whole bunch of other people playing. But no, I don't have a clear path forward for New Jersey or the nation. But I am confident that in these kinds of conversations, we're going to start to slowly chip it away at this behemoth of a problem.
Some confidence there. Thank you.
Yeah.
Question row 2, name and affiliation, please.
Hi, Nirav Vakaria, Cleveland Clinic. So question around, so you've talked nicely about how the social determinants of health has now come to healthcare, and we're very much a part of that in terms of what I would say is a case-finding approach. We have patients who come in, we know they're at risk, we find what their risk is, and we try to refer them out to social agencies, whatnot. But I'm curious about your thoughts on the role of healthcare in particular in preventing people from going off the cliff. So how much does their health impact their social risk? For example, when I see someone, I'm a physician, when I see someone with terrible back pain, my goal is to sort of get them somewhat pain-free, but my goal isn't necessarily to get them back to work. I'm just curious about kind of, especially as you think about what can healthcare systems do, how do we reorient ourselves to thinking about reducing someone's risk of falling off the cliff?
Karin, can you take that one?
So, and I'm going to go to as upstream of an example as I can think of in this moment. And so we've been doing a lot of work with our children's hospitals. And so when we think about a child who has asthma, who's on Medicaid, who's probably not living in the best of housing conditions, and we think about how we're addressing the asthma, the ripple effect of that is also how many days of school is that child missing? How many days of work is that parent missing? How are we sending them back into the same environment where we know they will have another asthma attack and will end up missing more school, missing more work, and ending up in, right? And so when we think about that long term, so we think about that over the 18 years of the child's life, how that impacts the school attendance, how that will most likely lead a mother or a parent to multiple part-time intermittent jobs. That, I think, is where healthcare can start to understand it's not just about making sure that the kid has the inhaler, but there is a role to play with these repeat customers and how that you know, in our instance in Dayton, Ohio, the Children's Hospital is now starting to truly get involved with Dayton Public Schools, with the housing authorities, you know, with reclamation and cleanup of properties, with holding, getting involved with the city of Dayton to make sure that living standards and codes are being applied. You know, it's not just necessarily treating the person, like you said, it's not just about addressing the back pain, but I do think that there is a place for healthcare to be able to enter into the social fabric and the social network to think about how they can be that policy lever, how they can use their political clout and their standing in a community to hold other counterparts and peers accountable around making sure that it's not just the asthma that's getting treated, but there's the conditions that this child can go to school and actually get a quality education. So I think when we think about that, you have to think about the ripple effects that are happening, and not just in the healthcare sector. The housing sector needs to understand that too. Yeah. You know, if the housing codes were up to how many ED visits may be decreased just by having the housing codes being enforced on the other side. So it's, again, mutually beneficial for us to be having these kind of conversations.
Good, strong response. We're going to close this out, and just please answer this in 20 seconds or less, each of you. Be a little strict about that. So in 20 seconds or less, Rachel, what are you excited about accomplishing in the next 2 years to have an impact on social determinants of health? Just one thing that you're excited about, you think it might pull off in the next 2 years. What is that?
Two things, still within 20 seconds. One is coming up with real guidelines for community clinics that are trying to implement social determinant screening, real guidance for them. The second is we've screened 30,000, we have 30,000 social determinant screens now in an EHR linked to community level data, full EHR data, and my team is going to be trying to at least start looking at some of these questions that we need to ask, which is which social determinants drive health, which social determinants referrals impact health.
Point well taken. Thank you. Karin, 20 seconds. What are you excited about?
So again, two things in the next couple of years. One is that the pilots that we've been running for the last couple of years will actually be able to start scaling across our 5-state footprint. We'll be able to move from hundreds of members to thousands of members and truly garner that data. But the second thing, and I think it's a big win for all of us that are involved, is to continue to push hard on the advocacy side and really look for the ways in which we have waiver authority to start demonstrations at the state level instead of at the neighborhood level.
All right, point well taken. Thank you. Carter?
I'm going to answer differently. I'm excited about publishing. Publish,
Really?
publish,
Yes.
regardless of
Please.
whether or not you think your results are significant. Put it out there. Don't be embarrassed. The field needs it.
Here, here.
Point well taken.
We
We not have
absolutely
thought of
need-
that.
Yep.
We need a lot more people speaking up about what they're doing.
Well, okay, you three are the best at doing it so far as I can see. That's great. Please join me in thanking Rachel Gold, Karin VanZant, and Carter Wilson. Thank you very much. Great point. Thank you all.